Welcome to MedEd's production of the SCRN exam review. My name is RoAnna Kingman, and this module is entitled Post-Acute Care. So our learning objectives for this module are to identify and understand the roles within the multidisciplinary team, as well as understand levels of rehabilitative care, identify nursing diagnoses and the plan of care, the nurse's role in early rehabilitation and discharge planning, and identify and discuss various assessment scales. Rehab is a multidisciplinary effort. It is important to understand the members of the multidisciplinary team. The team is led by physicians with training in physical medicine and rehabilitation, and they are called physiatrists. Neurologists who have specialized training or board certification in rehabilitative medicine. The rest of the team consists of neurologists, rehab-trained RNs, occupational therapists, physical therapists, speech and language therapy, social workers, psychiatrists, psychologists, and counselors. The physiatrist is responsible for physical medicine and rehabilitation management of patient care. The psychologist or neuropsychologist evaluates the cognitive and behavioral status of the patients, as well as assists in the adjustment to the illness and disability, this new disability the patient has, that now they have to cope with how they're going to function in their future life as compared to life prior to their stroke. They are also able to provide support to patients and their family, and as they do come to terms with those issues that are related to this new illness and injury. And of course, the registered nurse has the most responsibilities for their role. They're the ones that communicate the discharge plan to the patient and the family. They act as a liaison between the patient and family and the rehab team and the discharge planners. They also coordinate and provide all of the day-to-day patient care. And they are also responsible for educating that patient and their family in reference to their medical and health issues, as well as the skills that may be needed to provide safe health care. And first and foremost, and probably one of the things that we value the most as nurses, is to be a patient advocate. We advocate for the DME that they may need when they go home. We advocate for extra physical therapy if they want it. We advocate for family members to stay in the room if they want to stay in the room. So we are the ones that are really in tune with what is really going on with the patient, and we're able to help provide for their needs. Physical therapist. So the physical therapist works with gross motor skills. You'll definitely want to know that. He maximizes patient function by working to improve gross motor skills. They focus on mobility to include ambulation and balance and provide modalities for pain management. You'll also want to know the occupational therapist. That is the one that assists patients to return to maximal function with their activities of daily living. Activities of daily living, very important for you to remember. So that's fine motor movement. Speech language evaluates and treats cognitive, communication, swallowing disorders, as well as hearing deficits. The case manager and social worker. So when I was a nurse, I really thought that the case manager and social worker did absolutely nothing but walk around in their high heels all day. But as I became a nurse practitioner and I was treating these patients and I was ordering for rehabilitative assessment, I realized that their list of things to do is very long. And a lot of those things are things that I would never want to do. So they sometimes spend hours on the phone trying to figure out their insurance benefit information and find out exactly where these patients are qualified to go to, how many days they have, what kind of a facility they are qualified for. They also send paperwork and all of the notes back and forth to these facilities for them to analyze to determine eligibility. They coordinate the entire implementation of the treatment plan. They advocate for services for the patient and family. They are the liaison between the patient, hospital, and the payer. And as I mentioned just a minute ago, they provide all of the information to the insurance companies and coordinate the optimal use of whatever benefits that they have through their insurance provider. They also help people that maybe are unable to pay for the services of a rehab facility by helping coordinate Medicaid for them, or even a charity bed if that's available. They identify supportive services, resources needed after discharge, and then they link the patient and family to community physician services, home health care, long-term care facilities, as well as Medicare equipment providers. So when should we start rehab? So data strongly suggests there are there are benefits to starting rehabilitation as soon as the patient is ready and can tolerate it. All of our patients should undergo a formal assessment of the patient's rehab needs prior to discharge. This is one of our core measures, one of the things that needs to be completed, and one of the things that your stroke coordinator follows up on is that the patient must be evaluated by therapy. That is stroke number 10. That is item number 10 that has to be performed by us. So we need to determine whether or not the patient needs skilled nursing services or whether or not they need physician visits, because that really is going to determine what level of care they are going to need. So what are some examples of skilled nursing services that the patient may need? Bowel and bladder impairment, skin breakdown or high risk for skin breakdown, impaired bed mobility, dependence for ADLs, the inability to manage medications, needing someone to provide them to them, high risk for nutritional deficits. Maybe they're unable to feed themselves, or maybe they have a PEG tube. Some examples for a patient that may need regular contact by a physician: medical comorbidities not optimally managed like diabetes, hypertension, complex rehabilitation issues like orthotics, spasticity, bowel and bladder problems. Acute illness can be an illness that's not severe enough to prevent rehabilitation care, but definitely needs the oversight of the physician. And then pain management issues, someone that requires IV pain medication. Examples for a need of multiple therapeutic interventions include moderate to severe motor sensory deficits and or cognitive and or communication deficits. Early supported discharge. So when can we consider early supported discharge? You should consider this for patients with a mild to moderate stroke when adequate community resources for both rehabilitation as well as caregiver support are available and can provide the level of intensity of rehab services needed. Patients should remain in an inpatient setting for their rehab care if they are in need of skilled nursing services, regular contact by a physician, and multiple therapeutic interventions like physical therapy, occupational therapy, recreational therapy, speech therapy. If they need all of those things, then it is recommended they remain in an inpatient setting. So what is post-acute care? It's healthcare services that are provided after the patient is discharged from the hospital, and it is designed to support these patients in their transition from the hospital to their home environment and in their pursuit of achieving the highest level of function possible. So let's go through some of these levels of rehabilitation. You have your acute inpatient facility or your hospital environment. That is us. That is where they are when they have their stroke. The admission is near the onset of symptoms. The average length of stay for ischemic stroke is 4 days, and it is a 7-day length of stay for hemorrhagic stroke. The specialists that are involved are the MD and the RN, as well as OT, PT, speech language, and social workers can be involved as well. And you have access to any specialist that you may need for any other comorbidities for these patients. In the hospital, our focus is on getting those patients acutely stabilized and delivery of their acute stroke treatments. So our TPAs, our thrombolytic therapies, if they have cerebral edema, getting that under control, craniectomies, craniotomies, EVDs, all of those things, as well as initiation of prophylactic and preventive measures. We also want to perform a formal assessment of the patient's rehab needs prior to discharge. The next level of rehab is the highest level of rehab outside of the hospital environment. And this is an acute inpatient rehabilitation facility. This is the most intensive rehabilitation care, Admission is about 5 to 7 days after the occurrence, and the length of stay is an average of 15 days with a range of 8 to 30 days. Most of them are set up just like a hospital, So you have doctors, you have nurses, you have occupational and physical therapy as well as speech therapy, and sometimes you may have social workers as well. These patients require intensive 24-hour-a-day interdisciplinary rehabilitation care. It's provided under the direct supervision of a physician. So some of the Medicare regulations to be familiar with for an acute inpatient rehabilitation facility. Admission should really only be limited to patients where we are going to expect to see significant improvement within a reasonable length of time. And we are really thinking that these patients are likely to return to a community setting rather than being transferred to another level of care like a skilled nursing facility or a long-term care facility. These patients must be able to endure at least 3 hours of rehab therapy, PT, OT, and speech therapy per day for 5 days per week. Now those 3 hours don't need to be successive. They don't need to be 10 to 1 or 8 to 11. It can be 10 to 11 you have physical therapy, 1 to 2 you have occupational therapy, 4 to 5 you have speech language. So it's not successive, but they must be able to tolerate at least 3 hours of therapy per day, 5 days a week. Very important for your acute inpatient rehab facility. The physicians must have training or expertise in rehabilitation, and daily doctor visits are typical. RNs are constantly present. They are the ones that are caring for the patient in that environment. As I said, they are really set up like a hospital. Some of them are inside of hospitals. 2 of the hospitals where I have worked have had rehab centers inside of them. They just have to be distinct and separate, a distinct and separate unit from like ICU or step down. You can't have beds in there that are rehab beds. Literally, it's this whole separate locked unit. Or it can be a freestanding facility. We have a very large group or a chain of facilities called Encompass that are all acute rehabs. About 22% of our patients do go to an acute inpatient rehab facility, and these are the ones, remember we're looking at the NIH stroke scale score and looking at discharge disposition. So these are the ones that you get probably an NIH score of like 5 to a 13. They can be considered to go to an acute inpatient rehab facility. They have strict documentation requirements, and the patients must be seen by the physician. The physician must be involved at least 2 to 3 days every week during the patient's stay. So the physician must go in and review the treatment plans. They must attend conferences. Usually those are held every 2 weeks with the entire team. So during those conferences, typically it's going to be the physician, maybe the mid-level, the case manager, the nurse that's taking care of the patient, physical therapy and occupational therapy, and they can go through and look at the patient's improvement for the time that they have been there and determine how much more time may be needed, how much more improvement that they are expecting. So those are very important parts of being in an acute inpatient rehab. 32% of our stroke patients go to a skilled nursing facility or a subacute rehab. These are for stroke survivors who need daily skilled nursing or rehabilitation services on an inpatient basis and require skills of qualified healthcare providers. These are usually requested for patients who our rehab teams determine may not reach full or partial recovery, or if skilled nursing services are required to maintain or prevent deterioration of the patient. So just to give you an example, so if you have a patient that is 94 years old and has dementia and was already in a skilled nursing facility or a memory care unit prior to having a stroke, that person would not be someone that we would recommend to go to an acute inpatient rehab center. They are most likely not going to return to a community setting. They're not going to get better after a stroke than they were prior to having the stroke itself. A good patient for an acute inpatient rehab facility may be like a 56-year-old person that has had a stroke, that was working a full-time job prior to having the stroke, Or it could be a 70-year-old that plays tennis 3 days a week or is functionally active, drives, pays their own bills. They don't necessarily have to be athletically inclined, it's just an example. But they could drive, pay their own bills, perform all of their own activities of daily living. They were perfectly fine operating on their own in a community setting, and now they've had a stroke, and our goal is now to try and get them back to normal. So those are two examples of maybe somebody that would be a patient that would require acute inpatient treatment. Skilled nursing facilities must have rehab nursing on site for at least 8 hours per day. Medicare provides insurance coverage for at least 100 days in a SNF. Care must follow a physician's plan, but there is no requirement for the physician to daily supervise the patient. They can be standalone facilities, but if they are located within a nursing home or a hospital, they have to be physically distinguishable from the parent institution. It has to be a separate wing, ward, or building. A couple of the ones I've been in, you go in and it's like they have a central place there for the nursing station, and then one wing over here, it's almost like a star. So this edge of the star is going to be hospital. This edge is a nursing home. This edge is assisted living, and then this edge might be the skilled nursing facility. Long-term care or nursing home, it's for individuals who are unable to live in the community. Medicare does not cover long-term nursing home care. It is typically out of pocket and typically is very expensive. Some people do have long-term care insurance, and then Medicaid will kick in once all of their money has been depleted. Time of admission after acute event and length of stay is highly variable and usually involve mainly LPNs and LVNs and nursing assistants with limited involvement from RNs, OT, PT, speech language, and MDs. Long-term acute care hospitals. So these are for stroke patients with complex medical needs resulting from a culmination of acute and chronic conditions. So these are patients that maybe they're still on a ventilator, or maybe they still need significant pain management, or maybe they still have an EVD or craniectomy and their flap hasn't been put back in. It could be for someone like that. So these patients, these facilities must demonstrate an average length of stay at least 25 days. It's usually attended by an MD and RN with limited involvement from OT, PT, and speech because they're so sick that they are really unable to participate. Home health care agencies, 15% of our patients receive home health care. And that's really focusing on delivering that skilled nursing care and rehabilitative therapy like occupational, physical, and speech language therapy, as well as some limited assistance maybe by nursing aides with daily tasks or activities of daily living by home health aides. And they're also supervised by nurses. So typically what will happen there, the nurse will come out and do the initial assessment and determine what kind of services the patient will need. And then they'll determine on what basis and what frequency they'll come out. Encompasses medical and social needs and services designed to assist the patient in living in his or her own home. Most payment systems cover up to about 60 days of services. Home health care can also be performed in some assisted living facilities or other group homes, but if they are already receiving the services or the services are going to be duplicated at the facility in which they are living, then it will not be reimbursed. Medicare, they're eligible for Medicare if they are certified as homebound by a physician, and homebound means unable to leave the home except to receive medical care or have occasional non-medical trips. Outpatient therapy, so that's when you are required to travel from their home to obtain care at a hospital-based or a freestanding facility. Must be certified by a physician who is responsible for establishing a planned set of therapy services. And the therapy must be complex enough that it can only be performed by a qualified healthcare professional like a physical therapist, occupational therapist, speech therapist, etc. The treatment plans are usually sent to the physician and for review and recertification every 30 days. They must sign the treatment plan and send it back to the rehab facility with any changes or recommendations. Your outpatient therapies are good for motivated patients with good family support because a lot of times they're unable to drive to those appointments, so you really need somebody that's going to drive them and take them and help them to be successful. So some of the impact of the different rehabilitation settings on patient outcomes. Inpatient rehab facility patients have a higher rate of return to the community living setting and a greater functional recovery than SNFs and nursing home patients. SNF patients have higher rehospitalization rates as well as substantially poorer survival rates than inpatient rehab facilities. So the recommendation is that if a stroke survivor can qualify for access to an inpatient rehabilitation center, that they should receive this care over that care provided by a SNF. So we're going to move on to some of your post-acute complications that some of your patients have. You will need to pay attention to a lot of these, and I'll try and point out some of the things that are flags that you should flag on your slides or on your notes. Shoulder pain is present in up to 80% of stroke patients with upper extremity paresis, and that's due to traction on the arm during transfers and repositioning, as well as subluxation due to the weight of the paretic arm and poor positioning or support of that paretic arm. So as you can see on this slide, you have a bolded and highlighted and underlined area there. That usually means that I will want you to know that. So the most important thing is keep that affected extremity in a supported position. Other treatment options include progressive range of motion exercises, e-stim or electrical stimulation, heat therapy, and medications like anti-inflammatories or other analgesics. Nursing considerations are ensure proper handling of that patient during transfers, ambulation, and repositioning, and carefully position that affected limb at rest. Most of the time when I go in and I'm rounding on patients, the paretic arm is propped up with if they're unable to move the hand, you have a washcloth in there to try and prevent any contractures as well. Preventing skin breakdown, this is all inherent in our nursing DNA, I know, but just for quick coverage on this, I know you are all familiar with the Braden scale. So you'll want to perform regular skin assessments are recommended with an objective scale such as the Braden scale. We want to minimize or eliminate skin friction and pressure and provide appropriate support surfaces. Make sure that they're not sitting around in excessive moisture or perspiration or urine. Maintain adequate hydration and nutrition and regular turning at least every 2 hours. Ensure good hygiene with our regular baths that we are giving. Use special mattresses and proper wheelchair seating and cushioning to prevent skin injury. Prevention of contractures. So our patients should have passive and active range of motion exercises for those paretic extremities. It should include daily stretching, as well as application of resting hand splints for hemiplegic wrists and fingers. This is an important concept, the one that I'm getting ready to mention. Appropriate positioning of hemiplegic shoulder in maximum external rotation for 30 minutes per day. You may want to remember that. Application of serial casting or static adjustable splints to prevent elbow or wrist contractures, and resting ankle splints used at night and during assisted standing to prevent ankle contracture in hemiplegic limb. I'm sure some of you that are taking this class are familiar when we used to use old Converse tennis shoes, old high tops, and tie them up, and those were our ankle stabilization devices. Spasticity is velocity-dependent resistance to stretch of a muscle and is a component of upper motor neuron syndrome. Remember, we talked about that at a different module when we talked about the upper motor neuron lesions, which are present inside of the brain and the spinal cord. Those are central lesions. And spasticity is basically like a hyperreflexia. This does occur in about 65% of our stroke patients. Treatment includes treatment with Botox into the spastic muscle. Now, of course, we don't offer that in the hospital environment, but many neurologists do offer that in the office for treatment of spasticity. Passive or active range of motion, functional positioning, neuro-e-stim, splinting, and medication management with baclofen, dantrolene, and tizanidine. How do we care for these patients? So we want to remind our patients and encourage them to perform range of motion exercises throughout the day. If they are unable to perform those exercises, you can provide assistance, or the family members can be taught to provide assistance as well. Ensure proper placement of splints as well as when they need to be used and for how long. Swallowing difficulties. Very common after stroke and affect 42 to 67% of patients within 3 days after stroke. The key to this is early screening and identification to reduce the risk of developing pneumonia, malnutrition, dehydration, weight loss, and overall decreased quality of life. So the plan of care is determined by a clinical swallowing evaluation, initially done by the bedside nurse. There is no one specific screening tool that is recommended. However, a valid tool should be used. And then the patient, if they are unable to swallow, should have continued evaluation by speech if necessary to include instrumental evaluation. The speech-language pathologist may order a modified diet, like a pureed or mechanical soft diet, or thickened liquids, nectar or honey thick. And positioning, upright when they are eating. 45 to 90 degrees is preferred, if not contraindicated, and this is something you'll want to know. Chin tuck, head turn to the affected side if directed by speech-language pathology. Chin tuck, head turn to the affected side if directed by speech-language pathology. Guidelines recommend that enteral tube feeding should be initiated within 7 days after stroke for patients who have not been able to safely swallow. That's class 1 level A evidence. And I'm sure this is not new information for you that incontinence in our stroke patients is very prevalent. 40 to 60% of them have urinary incontinence during their acute admission. It does fall to about 25% by hospital discharge and then falls again to about 15% at 1 year. A thorough assessment of the function of the bladder is completed for all acutely hospitalized stroke patients. And we do want to try to obtain a history to see if maybe they were incontinent prior to having a stroke. We want to try to treat prompted voiding, pelvic floor muscle training for the bladder. Urinary retention is assessed through bladder scanning, and the way that we combat that is through intermittent catheterization after voiding while recording volumes. The recommendations are to prevent infection, to remove that fully within 24 hours after admission. Nursing considerations for incontinence and constipation are to establish a bladder and bowel training program, encourage mobility and activity to stimulate motility, emphasize adequate fluid intake and a high fiber diet, and then provide stool softeners and laxatives as needed. Some different neurological terms that I want to go over with you just for familiarity. Our first one is apraxia. So apraxia is a decrease or difficulty in performing purposeful, skilled, voluntary movement on command. More common after a left hemispheric stroke. You want to try to establish a routine for all tasks, as well as give them cues for a sequence of steps to take for those tasks. Aphasia is going to be the loss or inability to understand or express speech. We also have our Wernicke speech and we have our Broca speech, which we have covered in a previous module. If they are unable to speak or communicate, it may be helpful to utilize simple words and gestures as well as picture boards, and we certainly want to make sure they continue to have speech and language therapy. Patients that are experiencing hemispatial neglect or hemi-inattention, some of the interventions that we can use are a bottoms-up approach. And what that is designed for is to remediate attention processes for the left hemispace and internal representations of space. We also have a top-down approach that teaches the person strategies for compensating for neglect. Some of the examples of tools that we have are the PRISM adaptation, visual scanning training, optokinetic stimulation, virtual reality, limb activation, mental imagery, and neck vibration combined with PRISM adaptation to improve neglect symptoms. A couple things you want to remember with our patients with neglect: you always want to approach them from the unaffected side, So you want them to see that you're coming. If they're paralyzed on the right side, approach them from the left side, okay? Make sure that keep the call button on the unaffected side. Keep frequently used items close at hand. So if they use their glasses all the time, keep those at hand, the TV remote, etc. Deep vein thrombosis prophylaxis. In your immobile stroke patients without contraindications, intermittent pneumatic compression Devices, in addition to routine care, can reduce the risk of DVT, and this is what is now recommended. It's Class 1 level of evidence B. In our neuro guidelines, the benefit of prophylactic dose sub-Q heparin versus unfractionated heparin, versus low molecular weight heparin in immobile patients with acute ischemic stroke is not well established. When utilizing prophylactic anticoagulation, the benefit of low molecular weight heparin over prophylactic dose heparin is uncertain. Application of your intermittent pneumatic compression or sequential compression devices. What they do is spur blood flow by intermittently applying pressure on the calf muscles and the vasculature. Fortunately, it is no longer recommended that we use those TED hose, thank goodness, for those of you that remember putting those on. Impaired memory. That affects more than 1/3 of stroke survivors between 3 to 12 months after stroke, so it helps to use pictures, calendars, and memory boards, as well as exercise. Impaired cognition is our most disabling deficit and is often overlooked because it's hard to really evaluate. Utilize cognitive strategies to reorient them, use one-step commands, and decrease environmental strategies. Up to 80% report some depression after stroke due to loss of function, loss of independence, and alteration in brain neurotransmitter function causing depression. Treatments are antidepressants as well as psychotherapy. There is a guideline on the management of depression in stroke patients that I would recommend that you look up and read. We recommend that the nurses notify the providers if a patient has a change in appetite or a lack of interest or concern or enthusiasm, also called apathy, or if they are crying or extremely sad. It is important to use a screening tool to help identify early signs of depression. From what I have seen, most hospitals have a depression screening and depression questionnaire right on the patient's chart in their EMR, and that qualifies. What we normally do is go ahead and start them on a medication for depression. It's very helpful for them. The number one cause of stroke patient admission into long-term care institution is family caregiver stress and inability to provide care. Being a caregiver is extremely difficult. Those of you that have done it, as I have for my own father, know it can be extremely stressful. You can become resentful, not because you don't love them and not because you don't think you're doing the right thing. It's just that your life becomes not your own. Depression is very common in family members, over 50%. Our role is to continually assess the needs of our family and our caregivers. Further going into some of our devices that we use, so functional electrical stimulation therapy. What we do there is we place electrodes on the affected limb to cause movement of the limb. That continuous stimulation over time can provide some functional improvement. It's used for upper and lower extremity paresis as well as swallowing difficulties. Dynamic splinting is used with contractures in the wrist and hand to assist in straightening and function. Constraint-induced movement therapy, or CIMT. What we do there is we actually put a restrictive mitt on the extremity that is not affected to encourage the patient to use the weak limb. Therapy is about 6 hours a day, 5 days a week for a 2-week period. Brain stimulation, that's stimulation over the area of the infarct to help accelerate neuroplasticity. Virtual reality, computerized environment like the Wii. It helps the patient practice movements to improve mobility and strength. Mental practice, so the patient imagines moving the affected limb with the aid of audio recordings. It often is used along with CIMT. Mirror therapy. The mirror creates the appearance of the affected arm or leg moving normally in a 2-extremity activity. We're going to move on to assessment scales. We have the modified Rankin scale, which we've briefly covered in this module, the Barthel scale, the RANCHO scale, and the functional independence measure scale. The modified Rankin scale is the most widely used clinical outcome measure for stroke clinical trials and measures the degree of disability or dependence in the activities of daily living for people who have suffered a stroke or other causes of neurological disability. The scale runs from 0 to 6, from no symptoms to death. It measures independence rather than performance of specific tasks. And mental as well as physical adaptations to neurological deficits are included. This may look familiar to you. The breakpoints here are going to be, of course, 0 is no symptoms, 1 is no significant disability despite symptoms, but they are able to carry out all usual duties and activities. 2 is when you start to have a slight disability and they're unable to carry out all their previous activities, but able to look after their own affairs without assistance. 3 is when you become moderately disabled and they need help, but they can walk without assistance. Between 3 and 4 is when you have to utilize a DME or some sort of assistance to walk. 5 is bedridden, and 6 is dead. So the important things there are highlighted. Make sure that you are familiar with those. The Barthel scale, that measures disability or dependence in ADLs in stroke victims. It measures the patient's performance in 10 activities of daily living and is considered a reliable disability scale for our stroke patients. It separates the disabilities, the items, into groups related to self-care, which encompasses feeding, grooming, bathing and dressing, bowel and bladder care and toilet use, and a group related to mobility like ambulation, transfers, and going up and down the stairs. The maximum score is 100 if 5-point increments are used, indicating that a patient is fully independent in physical functioning. The lowest score is 0, representing a totally dependent, bedridden state. So this looks at a lot of self-care activities and mobility, and the score is between 0, which is the worst, and 100, which is the best. Here are the items that are included, and you can see how the scores are 0, 5, and then 10. Once you calculate the total score, that gives you an idea of their level of independence or dependency. So 80 to 100 is independent in the daily activities, 60 to 79 needs minimal help with ADLs, and then on down from there. Familiarize yourself with the scale so that you can be aware of if somebody is dependent or is fully independent. Make sure you know that 100 is the best and 0 is the worst. The RANCHO Los Amigos scale. So I had never heard of this scale in my entire life until I took the SCRN exam. It's also known as the level of cognitive functioning scale. Describes a brain-injured person's level of activity and measures awareness, cognition, behavior, as well as interaction with the environment. The scale identifies 8 levels of post-brain injury cognitive functioning and is utilized by medical staff to evaluate a brain injury, the patient's level of brain damage, as well as recovery prognosis. And this is what this looks like. It looks at their level of response. So level 1 is the worst, where they have no response to pain, touch, sound, or sight. And level 8 is going to be purposeful and appropriate. So that's the best. What you need to know here is that this describes a brain-injured person's level of activity. It's a post-brain injury cognitive functioning scale. The FIM score, or the Functional Independence Measure score, this tool is utilized by physical therapists and other healthcare professionals to measure overall independence during specific functional tasks, most often used in acute care. So I see this a lot when I go to the inpatient rehab facilities, and that's when you sit down every 2 weeks and you go through the patient's level of functioning. They'll bring this scale out and show you whether they are maximum independence or if they need help, max assist, etc., and I'll show you that on the next slide. It assesses physical and cognitive disability, and it is used, as I said, to measure their progress and their outcomes, as well as see what else can be done for this patient. Scores range from 1 to 7, with 1 indicating total assistance and 7 indicating complete independence. The possible score is between 18 and 126, with the higher score indicating more independence. So here you can see that the FIM score and your Barthel score, both the higher score is better than the lower score. Assessment scales. On here, this functional independence measure, the tool. So you can look at all of these items that they have here, all the way 1 to 18, and then over here on the bottom right, you can see 1 through 7. 7 is complete independence, 6 is mod independence or modified independence, 5 they need supervision, 4 is minimal assistance, and on down to number 1 where they need total assistance. Discharge planning and family training. So we should really provide hands-on with transfers, and we want to teach the families stand and pivot, modified stand pivot, sliding boards, and Hoyer lifts, as well as training with the assistive devices the patients are going to go home with. Walkers, wheelchairs, quad canes, the reacher grabbers, button hooks, sock putter honors, anything that they're being sent home with, we really need to train the patient and family on how to utilize them. When does discharge planning begin? So discharge planning begins on admission, and the goal is to assist that patient to achieve maximum functional capability, and it is based on their current function and pre-stroke function. The key to success for our stroke patient is going to be support, family involvement, community involvement, friend involvement, whoever they consider to be like family to them. It is important for us to know the family dynamics and who will be caring for this patient when he or she returns home. We do want to encourage the patient to be adherent with their medications. I'll give you an example of a patient that we did a stent on her. She was required to take aspirin and Plavix. The family was a little bit in denial that the patient had some beginning stages of dementia, so they sent her home by herself, and she stopped taking the aspirin and Plavix immediately upon going home, and unfortunately the stent reoccluded, and she ended up back in the hospital again. So however you have to do that, you need to establish who's going to be administering the medications to the patient. Facilitating referrals for follow-up visits, specialist visits, support groups, and other necessary community support like the library or Meals on Wheels if needed. What is the median length of stay for patients with ischemic stroke in the acute care setting in the United States? A, 2 days, B, 4 days, C, 6 days, or D, 8 days? The answer is 4 days. 4 days for ischemic stroke. What is the main reason that dysphagia increases the risk of mortality in stroke patients? A, decreased nutrition due to inability to eat. B, pneumonia due to aspiration. C, electrolyte abnormalities, or D, infection caused by long-term TPN. The answer is pneumonia due to aspiration. As previously mentioned in another module, if you need more time in between the question and giving you the answer, please feel free to pause the recording. Which of the following patients would be most likely discharged to a long-term acute care? A patient with a Rankin score of 3, a patient with an NIH stroke scale score of 5, a patient with a Barthel score of 19, or a patient with a FIM score of 100. So that's going to be C, a patient with a Barthel score of 19. Remember, 0 is worst and 100 is best. This person is probably going to need a long-term acute care facility because they're not going to be able to take care of themselves. This is the end of this module. I thank you again for your attention and your willingness to learn neuro. Have a great day.